Okay, Ron, wave at me when we're good to go. Okay, all right. Stretch break over. My slave driver. Got a lot of agenda to... So the next kind of theme that what we're going to talk about, so we've tried to get a handle on what palliative care is as a philosophy. It's not a patient, it's not a room, it's not a team. It's a way of thinking, a philosophy, a way of doing care. And now we're going to talk a little bit about how we integrate that into the work of a long-term care home. And it's quite unique because long-term care is different than a hospice unit. When people go to a hospice unit, they know that it's a specialized place to care for people who are dying. And in fact, that's what they're signing on for, right? They're probably end of life going to a specialized hospice unit. That's not true in long-term care. They're coming to you to be their new home. It's a place they're coming to live. And so how do we kind of grapple with that? We can get around it in our head that living and dying can occur at the same time, but how do we talk about it? How do we make that happen in our day-to-day work in our homes? And so one of the things that we've learned is to integrate palliative care into the home from admission to death is a process that has some key transitions. And so that's what I'm going to talk to you about now. The first transition is actually when someone is admitted. And when someone is admitted, do they need to know everything about your palliative care program? No. That's not what's on their mind. In fact, they're so overwhelmed by all of the changes and the new experience. But you know what they want to know, the resident and the family? They want to know that we will care for you for the rest of your life. And if you want to stay here for the rest of your life, we provide care for life. We will be able to look after you. Because I was so surprised in the project that sometimes when residents were approaching end of life and the family sent them out to hospital, it was because the family said, I didn't know that the long-term care home would be able and willing to keep my loved one, my family member, for the rest of their life. And somebody else said it earlier, many times it's not in the resident's handbook. It's not in the orientation material that families get on admission. So what families want to hear is just, we provide care for life. We will care for you for the rest of your life, and maybe put a little brochure in the package that families get, and make sure there's something in your resident handbook that when the time comes, you've kind of laid the groundwork for that kind of conversation. And then the next time is when you have a chance to sit down with that resident and the resident's family members, power of attorney for personal care, and talk about what their wishes are for the end of their life. And I'm not talking about a medical directive here. That's a small part of it, whether they want different levels of care, whether they want to go to the hospital. But what about their spiritual and cultural preferences? Do they want certain family members to be with them? Do they want to be very private? what are all the things that we need to know about somebody to care for them really, really well to the end of your life? And you want to know what those things are. You find out a lot of that stuff just incidentally through your conversations. But advanced care planning is much, much more than medical directives. And this idea of introducing a palliative approach and the idea of talking to families about advanced care planning can happen earlier in the stay in long-term care, before the person is imminently dying, and you can have those kind of conversations as part of getting to know the person. Then there's a transition where, and we talked about how you kind of know when that person is starting to transition, things are changing, and the focus, it's not that you no longer are doing restorative care, but the balance is tipping a little bit more to be a little bit more focused on palliative. And then transition to end of life. And then after the death, a really unsupported area I found in my work was that area, the time of bereavement, the grief. For families, for other residents, and for staff. And Jackie will tell you, how we learned very much about the tremendous, because you talked about the very close personal relationships that you form. You have family-like bonds with some of your residents. And the grief that you feel is normal, but it isn't always appreciated, and you don't always have the support for your organization. Yes?
I would like to hear how others' homes are doing after somebody passes. What kind of support you provide to the families? Because in our home, we did bring it to the subject, and we found out we didn't have funds to continue the support after.
We'll talk about that later, and we have for staff, we have a post-death debriefing as well. So thank you for that comment. So if you were going to draw a diagram of what this comprehensive palliative care program looked like, you could think, okay, here's when my resident is admitted to long-term care, and here's when they die. And I mean, that could be any length of time, but let's just say it's 2 years. Could be 1 year, could be 5 years. And when that resident is admitted, even though most of the goals, most of the focuses of care are on restorative, right off the bat, you recognize that that is probably the resident's last home. They are probably not going to go home from there, and they will probably stay with you to the end of their life. So this idea of the diagram is supposed to help you see that when you have a care plan, you can have goals of care on both dimensions, both restorative and this palliative philosophy that focuses on comfort and dignity and quality of life right from the beginning. And it's over time that it's just that proportion changes. And each of these bubbles represent the thing that I talked about earlier, one of the transitions. So if you have a comprehensive palliative care program in your home, there's something that should go on at admission, something should go on when you start to see that they're changing and their goals of care are starting to shift to be more palliative. Then there's that more imminently dying bubble, time of death, and bereavement. So doesn't happen like at one time. It's a progression that gets integrated into how you think about how you deliver overall resident-centered care. I really like the person's comment that it's just part of that resident-centered care. And this squiggly line means that there are ups and downs. You know, we can't always predict. So at admission, I said this, what a family member wants to hear is we can care for you for the rest of your life. That builds the foundation for future conversations. Most of it is about having the conversation. And that's not always easy. When we started the project, we gave Jackie and all her colleagues of all disciplines a survey called Attitudes Towards Care of the Dying. And you know what all the staff said? Talking to families about end-of-life care wishes and end-of-life issues, very, very important. But we're not comfortable and it's not my job. Everybody said that. So no wonder nobody was having the conversations with the families. Although everybody knew that somebody needed to do that. And you know whose job it is? Every single person that works in the long-term care home. It's all of your jobs to be comfortable with that. And if you say that right from the beginning, you build that foundation for later in the journey where people are starting to change, when people are beginning to recognize that the goals of care are shifting, that people are sick enough to die. It's not, and families would say to me, I can see what's going on, I'm not stupid. And I want to talk to the staff, and nobody will talk to me. Nobody will talk to me about this. So who's in denial here? It's not the family usually. So it just helps if you lay the groundwork at the beginning. It's like you're giving permission to have this topic as part of the agenda. The advanced care planning, I talked about that. And again, the timing is important because families say, we would like to have these conversations early, and we would like a member of the staff in the long-term care home to initiate it. So it might not be the PSW, but the staff, the family member is often going to go to you and say, do you really provide palliative care here? Or my family member really has these wishes. And you can help facilitate them sitting down with whoever the appropriate person is in your organization to do that. You got to know the resident, and they want to talk to the person they think knows the resident best. They don't care if it's life enrichment or the RN or whoever. They want the communication to be really clear, and you've got to make sure you're dealing with the power of attorney for personal care or the right substitute decision maker. And you want to have, we talked about education and training, and we really need to make sure, and we have some resources in our toolkit specifically for training in advanced care planning conversations. These conversations are ongoing. You do not do it once. You do it and revisit it at these different transitions, those different bubbles that I talk about, and they include talking about the treatments and interventions that are offered in your home, making sure that they know what palliative care will offer them in your home. A team approach, more support for their comfort, more pain and symptom management, maybe extra visit from a pain and symptom management consultant. And you get the resident and family knowing how they can communicate the changes and what they want to know. Not every family wants to know the same thing, but what do they want to know, and how do they want to know it, and who do they want to talk to them? And then when you get to that transition, that point where the goals of care are much more palliative, you really want to be able to identify that point, and we'll talk more about some resources that will help you do it. And personal support workers are key to identifying that transition, because you know. And then that's a really important time to have a care conference. And my colleague, Deb Parker, has done some excellent work on that. So I'm going to turn this over to you. Green means go.
Okay. Am I on, Ron? Yes? Great. It's great to be here with you, and I must say that I'm not sure with such short notice that we gave you that I could have got 120 personal support workers to come to a workshop in Australia. We do try and work with personal support workers as much as we can, but I think that the work that Mary Lou has done and your enthusiasm today is really amazing. So my background is I'm an aged care registered nurse, and I worked in both hospitals and long-term care for many years. But I've spent almost the last 20 years as a researcher attached to either a specialist palliative care unit or currently I'm attached to a large aged care provider that has 50 nursing homes. And 160 community nursing services. So I hope I bring that experience with me, that I'm clinical as well as doing the research in this area. So let me see what we've got. So Mary Lou's got bubbles. I'm a little bit more linear, and I've got flowcharts. And so it's probably a little bit hard for you to see it from the back, so I'm just going to go through. So we've got in Australia, this is our new model of palliative care for long-term care that fortunately I've received enough money from the government in Australia, who are incredibly supportive of palliative care and long-term care, to actually roll this out across the entire country, and there's 2,700 long-term care facilities in Australia, and we're currently doing that. We've been into doing workshops with 550 of the nursing homes so far in the last couple of months, and over the next couple of years we'll be doing all 2,700. It's quite nice to come to Canada and have a little bit of a break. So trajectory A is the expected prognosis of greater than 6 months, and really that's what Mary Lou's been talking about. It's the advanced care planning. So it's when people come in, it's the opportunity to have that. We don't do it like you don't. We don't do it the day they arrive. They're far too overwhelmed. But we do say probably in the first month that's a good idea to start that conversation about that. Now that will change depending on if people come in with a very short trajectory, and you might have to move across a little bit quicker than that. And for those people, we say that you should review that advanced care plan and what they're happening every 6 months. And I really like that idea, Mary Lou, where that doctor said if they're changing month to month, then they've got months to live. And I think that's really a handy tip. The middle one really is what we're talking about at the moment, where we call that the palliative phase, where you've got an estimated prognosis of 6 months or less to live. And this is the case conference idea, the family meeting, some people call it, or case conference, but also to look at some of the common symptoms that people might experience at that time, and to really get on top of that. And we'll talk about pain and dementia a little bit later today. And for those people, because they've got that less than 6 months to live, it's really important to do a good review of those people every month to make sure that you're on track with what's in the case conference plan. Are you doing that? The worst thing that can happen is if you have this fabulous case conference family meeting and you set this really good plan of care and then nobody actually actions it, and that's very frustrating for the families if you do that, if you set up that expectation and then you don't work through. And the last trajectory I'll talk a little bit more later, which is the terminal part of the trajectory, where really you're looking at weeks to live, and we use an end-of-life care plan in Australia specifically designed for long-term care. So the palliative care case conference. So when would you begin a palliative care case conference? So we've said that it's when somebody has an approximate prognosis of less than 6 months to live. We don't use the palliative performance scale in Australia, but I think the trigger is 60 or less. Palliative, yeah. So if you are using the palliative performance scale, at this point you'd be looking for a score around 60, if that's the one of the measures that you're using. Some of the things that are fairly consistent across the world about how you might recognise who's entering this phase, if they've had multiple readmissions to hospital for a variety of things, if they're getting recurrent infections, and that can be a chest infection or urine infections, that's a sign that the body's not coping. Increased weakness and fatigue, and it's really hard in this area where you're dealing with a fairly frail population to start with. So when you're dealing with a cancer population, when it's quite obvious when people get to this point where you can say they've got fatigue or they're weak, because it's a really obvious change. But in the people that you're dealing with, it's a much less obvious change to see. Decreasing oral intake and weight loss, and again, particularly for people with end-stage dementia, this can be quite slow, could happen over many, many months. For people who don't have dementia, it may again be a little bit more obvious. And the increasing care needs. So you're having to do far more for these people than you were previously. And also that at this time, the family may actually be seeking you out more because they're recognising that this change is occurring and they're needing more input from you about like what's happening and, you know, where we're going with this, and, you know, if they've been to hospital, you know, the whole support around that. And as Mary Lou said, that the surprise question, would you be surprised if this resident died within the next 6 months? And when we were doing the pilot work to develop the resources that we're using across Australia, I actually got the nurses to sit down with the nurse practitioner in the homes that we were working with, and I got them to categorise people whether they were more than 6 months, less than 6 months, or terminally ill. And then the nurse practitioner sort of worked that through with the staff, and they were incredibly accurate of the people who they picked in that less than 6 months. We then followed until they died, and most of them did actually die within that period. So I think that you're highly skilled in this area. You do know your residents well. I think that's been really obvious from the conversations that we've had already this morning. So what do I mean by palliative care case conference? And often in Australia, when I tell people that I'm going to talk to them about how to do a palliative care case conference, the RNs in particular always say, oh no, we already do that. You don't need to tell me about that. I do that all the time. That's a routine thing that we do in our facility. And so I say, okay, well, just, you know, work with me and let me explain to you what I mean by a palliative care case conference, and then we can have a conversation about whether what I mean and what you mean are the same things, and inevitably they're not. So what the RN usually means is that they work through, you know, a funding type based tool where they go through all of the systems, you know, so continence, wounds, you know, the drill, all the physical stuff, you know, a little bit about spirituality, psychosocial care. But what I'm talking about when we're talking about a palliative care case conference for people who have 6 months and less to live is that you have to get down to the nitty gritty and the far more difficult questions than you're just talking about people's continence level. And that is where the RNs in particular get cold feet because they are difficult conversations to have. So we do find that we're not talking about the same thing. Who should come to those case conferences? You should. As personal support workers in Australia, you are as valued as the team as you are here. And so we encourage you to come. You are the frontline workers. You do see the day-to-day changes. And the family actually like to have you there. You know, you are a very familiar face to the family, perhaps more so than the RN. We do like to get the GP along or the medical director along because there is conversations to be had and decisions to be made that do require either a GP or a nurse practitioner, somebody who has the authority and the ability to change medications, to cease medications, things like that. Spiritual care, all the team, very important to get along. One of the things that frustrates GPs in particular, if you're going to call these meetings, and they take anywhere from half an hour to an hour, is if you come along and you are not prepared. So if you know that you're going to be the coordinator of a case conference, and we say that usually that's an RN to do that, or I think you call them RPNs. You need to make sure that you have the up-to-date assessment of what's going on for that resident, the medication charts. You need to understand who's the substitute decision maker, are they in the room, what sort of advanced directive or advanced care plan has the person got organised. The person themselves can come to these case conferences, and that caused an enormous anxiety amongst the staff, because it does change the dynamic. Having somebody at their own palliative care case conference means that you have to be quite sensitive about what's said, you have to be inclusive of that person. And in the study that we did, about 20% of people came to their own case conference. The other people who unfortunately were too unwell or who had too much cognitive impairment. So you can invite the residents to come into their own case conference. You need to be organised. As I said, we have a checklist and as part of a toolkit, and certainly happy to share that with you. And we've got a little video, which I think we play after lunch, about that. And it's also important, as I said, to once you've had this case conference and gone through some very important discussions about, not only symptom management but goals of care, places of care, what are the family concerns, that you follow up on that. So it's not just an event that you do, but it does need to be followed up. So then if we move to end-of-life care, so that's our final trajectory. So for me, end-of-life care in Australia is terminal care, so that's the last couple of weeks of life. And I'm not sure if you can read down the bottom there from the back, but we've got end-of-life is urgent care. You only have one chance to get it right. So, as Mary Lou said, everybody dies, but you only get one chance to do it right, for most people, I would say. So this is that trajectory on the side here. As I said, expected prognosis of less than a week. We have something called the residential aged care end-of-life care pathway. Look, it would be suitable for you to use in Canada if you're interested, and perhaps I'll get Kathy to blog or tweet what she does, some of the resources that we have available, or you can contact Mary Lou. Really, it's just a formalised plan where it works through the things that you need to do, and we'll have a quick look at some of those things. But how do you figure out when somebody has days or weeks of life to live? So how do you know? And this causes enormous anxiety when we first start working with homes about using an end-of-life care plan. Who do you put on the plan? Can you put somebody on the plan and take them off the plan? Yep, absolutely. As we know, Mary Lou gave an example. Somebody could look like they're dying one day and they're eating their scrambled eggs the next. So yes, they can come on. But these are some of the triggers that we found in the work that we've done, that if you have 3 or more of these, then you might be somebody is terminally ill. And in actual fact, in the analysis that we've done recently of the work, we actually found that most people who got put on an end-of-life care pathway actually had 7 of these, so 7 of the 9. And for those people, most of them died within a week. So I think 3 is conservative. I think you'd probably be looking potentially for more. So experiencing rapid day-to-day deterioration, that's not reversible. So that fits in with Mary Lou's thing. If people are changing day-to-day, they might have days to live. Profound weakness, so people who can't lift their head off the pillow. So, not just a bit of weakness, but profound weakness. Again, requiring more frequent interventions. At this point, people may start to either refuse or be unable to take their food, fluids, or even oral medications, and that's when you have to think about getting the GP or the nurse practitioner in and actually changing their medications, if they're on oral medications, into something else like subcut or patches. Irreversible weight loss, increasing loss of ability to swallow, changes in breathing patterns. So people sometimes get that horrible gurgly sort of Cheyne-Stokes breathing, that's very end stage, really. If you're at that point, you certainly know that somebody has got days, if not hours, to live. Lapsing into semi-consciousness or being unconscious. And an acute event has required that you're thinking about treatment goals. So sometimes people tip over into this terminal phase because they have an acute stroke or something in their comorbidities actually indicates that something fairly drastic has happened. So that might happen quite quickly for some people. So as I said, we've got an end-of-life care pathway. So what do I mean by care pathways? So they're structured multidisciplinary care plans. So it's not just for the nurses to use, although there is a section specifically geared towards personal support workers that you fill in every 4 hours, and it's based on common symptoms and psychosocial care. So as I said, the RAC EOLCP for short. Is an evidence-based one that we use in Australia, and the staff that use it do find it just a handy sort of signpost document. These are the different sections in that pathway. It's was based on the work of the Liverpool Care Pathway, but if you've ever looked at a Liverpool Care Pathway, it's about 20 pages long and it's incredibly complicated, and it's really designed for acute care people, and when we showed it to the nurses in the long-term care, they said, there's no way we're doing that. You need to make it far simpler and user-friendly for us. So the team has done that. So the comfort care section is really sort of the engine room of that care pathway, and as I said, that's where you've got a list of common symptoms, and every 4 hours you would go and you would assess whether that person has those symptoms, and if they've got any issues that aren't being met, then you would do some action and follow that up as part of the pathway. So it's designed to be an all-encompassing document that actually replaces your documents instead of writing in your own care plans. But it's got, it's multidisciplinary. There's places for everybody to write things on. The first couple of sections are really about having a very good look at what's happening at this point. Who is the substitute decision maker? What's the advanced care plan or advanced directive? Ceasing medications, and you need to get the GPs or the nurse practitioner on board with this. This isn't just a nursing document, because at that point, there's no point giving people medications that are for their cholesterol when they've got a day to live. At this point, you do need to stop those things, but you don't have the authority to do that, and the GP needs to do that. Hopefully they'd be stopped well before that, but not always. And then there's a section on after-death care, which is, the obvious things about who to notify and what to give the family in terms of bereavement support.
In communications, I see a little bit of a medical model in here, and that's the communication is staff to staff, staff to residents, and I'm looking at how we can involve, so it's families to staff. Mm-hmm. Because families are actually the experts on the people they love. Mm-hmm. And if we keep thinking that we're the ones telling them, we're following an old medical model that I wish could become outdated in long-term care, and make families a part of the care plan. Yeah. Those families who wish to. When my own mother died, it was myself and the PSW doing the work in her room.
Can everybody hear?
Yes.
Good.
And there's a PSW and myself who figured out what had to be done with the RN running in to give the morphine, but we did the end of life care, and I felt like I was part of the end of life care. And so as a social worker, I say, as a family, don't sit passively at a care plan meeting. You're the experts. Yeah. It shouldn't be telling you what should happen. It should be a quote. So I would almost like to see that double arrow be.
Well, it's supposed to be, what this is supposed to mean is residents and families speaking to the staff, but you're right, I should change the way the slide is structured. Okay.
I actually put that first.
Point made. Agreed with. Yes.
I just want to reinforce what my understand even the language, even English. And if you speak with the family, they may be able to talk to the resident in the language that she understands.
Yeah.
Like my case, for instance, when I get old, I think probably I will be able to understand more who speaks to me in Portuguese other than one who speaks to me in English. So it's a very important point. Speak and focus. Speak and focus on the family, because they can touch to key points that will ignite that will well, I won't, because I scream when I talk, so I don't think that. So I can't even stand up. I think what she said is very important, because if you can speak the same language, you can get a better reaction and be more effective, other than the whole thing you've been doing so long. Thank you.
Okay, thank you. So I'm going to motor along. We're about 5 minutes from the break, so just hang in here. So in our toolkit, and we've got all these resources online, and they're all free for your homes. Although if you want to buy hard copy, you have to pay for the printing, and we have a sign-up sheet for that. I don't mean you personally, but your home. But they've instituted a lot of different tools to help get the conversation started. And some of those tools are when a resident has died. I'm not going to talk about these because Jackie's going to talk about them in the afternoon, so I'm just going to move on. I'm going to move on to bereavement support, and there was a question about bereavement support, and it is an area that we found to be very neglected in the long-term care environment for residents, for staff, and for families. And I'll talk in a few minutes about what we instituted for staff, which is a post-death debriefing and what we call the input model. For families, actually the personal support workers are extremely important in the grief support aspect, because they do have those family-like bonds. The personal support workers are now, they've created their own type of sympathy card, which Jackie will talk to you about. And we also encourage them to go to a grief support group that is run by our hospice volunteer visiting program if they want to take advantage of that. For the other residents, I think that it's just tragic that people don't include the residents in talking and reminiscing about the death of another resident. When I die, I sure hope someone notices. And they don't just carry on as if I was never even, alive and living. And I know there's some ambiguity about what you're entitled to, but I'll tell you, death is, if you say that someone has died, that's in the paper, that's public information. The details of their care and their health condition, that's private, that's confidential. But the fact that the person died is not something that is a secret. And unless we quit making things a secret, it's going to be very, very difficult. So grief is normal. And it's a healthy, natural reaction. And I'm telling you, if you didn't grieve the loss of your residents, I would be feeling that you didn't have that emotional attachment that I hope that you have to provide them with good care. It's two sides of the coin. You can't have one without the other. Everybody's grieving experience is unique. Some like to have people to gather around them. Some like to be left alone. You can't judge. There's no right way to grieve, but you have to respect that you give people space to do that. And it is ongoing. These are some of the normal emotions. We used to think, remember there was the old stage theory of grief? First you were in denial, then you were angry. Well, we don't believe that anymore. We believe that somebody described it, it's like a beehive with a bunch of bees coming out. You know, anger, sadness, depression, loneliness, hopelessness, numbness. Sometimes you feel all of those things at once, or sometimes you feel some of them or not all of them, or in a different order. So there's no formula. But these kinds of things are normal, and you're going to see them in the families. You're going to see them, and you've got to know that it's not about you. I mean, that's a really important thing for you to do, is appreciate if somebody gets really angry at you, you might have just come in at the wrong time. And so, you know, I really have appreciated how much support the personal support workers give each other around helping one another debrief and support each other with all of these kinds of emotions. And the same emotions in the other residents, people who have sat, and my very good friend, her mother is end of life in long-term care, and she went to visit her not too long ago, and she was having a good day and had gone to the dining room, and she and another resident were sitting at the table holding hands, you know, and she thought, well, how lovely is that, you know, that this resident is going to really be impacted when my mother dies. And compassion fatigue refers to that cumulative impact where you've done an awful lot of caring and you're just overwhelmed by that caring. And it's experienced when you have to do the care and experience the loss again and again and again. And it can build up and almost become like a traumatizing kind of experience. So self-care is so important to support one another and help you prevent that kind of compassion fatigue that gets you to the point where you just can't go on. These are some of the things that you can do, and if you look at them, most of them are things you shouldn't do, okay? Don't provide platitudes, you know, and a platitude is, you know, well, you'll get over it, or it's a fact of life, or, you know, that's not very helpful, you know. Just don't judge them. Listen, validate. It's normal. You're doing the best you can. Do you know what? Everybody's doing the best they can. Even if it doesn't look very great, usually they're doing the best they can. So validate that, don't judge them, help them find their strengths. A good question is, you know, when you've had a difficult experience in the past, what are the things that have really helped you get through it? Think back in your own life. Where do you gain your strength? I mean, it'll be different for everybody, but remind them, help them kind of remember what their inner resources and their strengths are. Encourage them to reach out. Many people's reaction to stress and tension is to pull in, you know, leave me alone, go away. And actually that's okay for a while as people kind of regroup, but it's really helpful to reach out and get support from others. And don't make any assumptions about what people need. Ask them what they need. That is, without a doubt, what can I do for you? You know, do you need me to go and look after your resident for a few minutes so you can pull yourself together, or do you need me to get you a cup of coffee? These are not to do. Don't blame, don't scold. Try to make sure that past traumas don't get kind of caught up in this situation. So maybe an individual's had an experience with a bad death in the past. This is the new experience, a different experience. Try and help people keep things separate. Don't escalate it. I mean, how many of you are parents? You know, with your kids, sometimes the smartest thing is to walk away, because it doesn't matter what you're going to say. They're not going to hear, and you're just going to escalate it. So you back off, you regroup, and you find a different time or a different, same thing here. Don't give people all kind of expert advice. I am the best griever ever, and this is what I do. Or not what if this, what if you do that? You know, so these are things to avoid. Okay, so we'll take a couple of questions if you want, and then we're going to go to break because I think the coffee's there. Yes?
There is something that you said that I don't want it to be missed here.
Okay.
Because oftentimes when a person passed on, it becomes so private. But just think about yourself, for all this tremendous work you do, and doing that it is just buried with you, that will be a total loss, especially for us behind. And I think about Mandela. If it was just a private thing, what a loss this world would have not knowing the footprints that he left on the sand. So thank you.
You're welcome. Can I ask the participants to sign in for their continuing education certificate at the registration desk? So when you go out for coffee, there's a sign-in sheet to get your certificate. That does not mean you can go home, because you have to come back and you have to finish the workshop. We are running a little bit behind schedule, so would you be okay to have a 15-minute break instead of a half an hour? Yeah, and we'll get back to it. Okay. So, Jackie, what? Oh, wait a minute. One more comment here. Just a sec.
Hello?
Yeah.
I just got a quick question. In response to what we were talking about earlier with grief and coping, right?
Yeah.
One of the tools and approaches that our long-term care home has taken is that we realize that the resident that comes into our home, we are just part of their journey. Yeah. And even in death, we celebrate the person's life, and we recognize that on admission, the resident came through our front doors, and we welcome them. All staff welcome them. And there is a farewell ceremony also, that when the resident passes away, we include all residents and staff before that person's they leave their home, in fact, that they are not taken out through any back door. They would go through the front door the same way they arrive, and the residents and families and staff have the opportunity to say goodbye. And that it means a lot to the family and other residents that everyone is involved. Yeah. And it is such a wonderful thing to actually see that, because the families especially, they're so very thankful, and that so many people care and residents care, and the residents who build a relationship, they are there to say goodbye also. So it is a wonderful thing that I hope to see, continue on in many homes.
Thank you, and that is something we endorse. And we'll you know what? Let's take the break. We'll come back, and I'll give you a chance. But it is a community event.